Okay, what about now? Do you hear things now? So I switched mics. That should do it. Okay, good. So I'm gonna start off doing the cases. I don't know if she did it in class or not, but so I have this cases to do, and then I have a Kahoot as well. So we'll do the Kahoot at the end. So the diabetic cases. So did she do this at all, or she did her own review? Not sure of the delay, so I'm just gonna wait a second. No? Okay, good. So we're gonna go through this one, and it should be posted already, but if not, but this should be posted. This diabetes cases. So we'll go through this. I know there's a bit of a delay with the chat, but we'll do what we can. Um, okay, so history on a new patient. She's a 49-year-old female. She comes in from mild asthma. Recent visit, you performed some tests for cardiovascular risk assessment. Results showed fasting glucose that was elevated. You contacted Ms. Riddell and arranged for some further tests to be done for her to come back for review and discussion of the results. Past medical history, mild asthma, no other chronic medical problems. Medications, she's on Ventolin for asthma as needed. Social history, married, 3 children, gave up smoking 2 years ago and works in a supermarket. Family history, mother had type 2 diabetes, dad, and died of an MI at age 67. So vitals look okay. Blood pressure starting to creep up a bit, 136/82. Um, Pulse 80 regular, it's good there. BMI 29 starting to creep up. So general, well-developed, well-nourished female, no acute distress, overweight. HENT, atraumatic, normocephalic, sclerosing-ecteric. Cardiovascular is all normal. Pulmonary, all normal. Clear to auscultation bilaterally, no adventitious breath sounds. GI is positive, all 4 quadrants. Non-tender, non-distended, 2 peripheral pulses. Neuro's okay. Fasting glucose, 120. BUN 18, creatinine 0.8. TC is 160, LDL 90. Oral glucose tolerance test, 160. So remember what the magic numbers are for diabetes. 126 for that fasting glucose. And what the results are for the OGTT. So how would you classify her right now? She is considered pre-diabetic. She doesn't have the criteria yet for full-blown diabetes. So you discuss lifestyle approaches to managing her condition. Have her go see a dietitian for specific dietary advice. And in accordance with guidelines, you also recommend some moderate physical activity. So remember, always like pre-diabetes, most of it is just going to be like lifestyle modifications. Give them 3 months, 6 months, see how they do on their own. So when you want to see her again, 3 to 6 months to a year. She's not diabetic. She has no other major risk factors right now. So 3 to 6 months to a year, have her come back in and check how things are going. Well, she gets lost in follow-up. So she finally comes back a year later. She made some lifestyle changes, but found them difficult to maintain. And you perform a physical exam and you repeat her blood work. So now, pulse 84, regular rate and rhythm, still doing okay. But look at her blood pressure now, 160/90, starting to creep up. And she gained some weight, so she's now overweight still, but BMI is now 30. Okay, so her lifestyle modifications weren't really good. They didn't do much for her. She found it hard to keep up with. This is your normal patient. This is what's going to happen a lot when you see them. HENT is still normal. Cardiovascular is okay. Palm is okay. GI is okay. Extremity is okay. And neuro is still okay. Now, fasting glucose, 145. So now we're well over that 126 threshold. BUN and creatinine is still okay, so her kidneys are still okay. We always make sure that the kidney function's good. Total cholesterol is 180, LDL 100, and now her A1C is 7.5%. So it's already to creep up, 7.5%. So her fasting glucoses were probably around like 160, 170, I think. I remember there's a conversion table that shows what happens with the conversion from A1C to glucose. You don't need to know that for the exam. But again, obviously, we know the higher the A1C, the higher their average sugars have been running. So, based off the recent lab results, you conclude commencement of oral hypoglycemic drug treatment. What's your drug of choice? Always first-line therapy whenever it comes to diabetes, especially type 2, obviously, not type 1. Type 2, always start metformin 500 PO/BID. Very, very easy dose. Remember the biggest thing with metformin, it doesn't cause any hypoglycemic events. So they're going to tolerate it very well. Would you advise any blood glucose self-monitoring? Because it's metformin and it doesn't cause any hypo events, you don't have to do it. But if you want to get the patient in the habit of starting to check their sugars, they can do it, 1 or 2 times a day, 3 times a week. But remember, again, it doesn't cause any hypo events. So it's not mandatory. Would you prescribe any other drugs at this time? So again, this is endo with diabetes. However, you still got to take care of your patient. So they did have some blood pressure issues. So maybe put them on an ACE. Now they're starting to creep up with the obesity, high blood pressure. Now they're diabetic. So now they have risk factors for diabetes. You can put them on risk factors for heart disease. So you can start them on an aspirin. Statin, their LDLs are on 100. Remember what the goals are. So remember when you're studying, remember what the guidelines are. So we're starting this patient on medications to lower the sugar levels. We want to see them back 3 months and recheck that A1C. Remember, A1C takes 3 months because those red blood cells last for 100 days. So always make sure you wait 3 months and see how they're doing. So over the next 2 years, you're still seeing the same patient, but she's taking her medications, but obviously she's not following her dietary restrictions and still eating all the sugars and the sweets. Remember also, when it comes to diabetes, it's not just the sugars. Also remember, it's the breads, the flours, stuff like that. So yes, Imani, 81 milligram aspirin, perfectly fine. Just daily will do enough. You don't need to do the full strength or anything. So over that time, our patients maxed out her metformin. Remember, maxing out metformin is 1,000 milligrams PO/BID, so 2,000 daily. She's maxed it out. She's reporting some blurred vision now. Again, blurred vision is due to elevated glucose. Also, bruise on her shin. So you now perform an exam and you repeat the labs. So for vital signs, 76 regular rate and rhythm, pulse, that's good. BP 124/72, so that lisinopril, hopefully that we prescribed 2 years ago because her blood pressure was high, was doing very well. She's gaining weight. BMI is now 31, so she's considered obese when you do your general exam. HNT is still okay. Cardiovascular is okay. Pulmonary is okay. GI is fine. Extremities, 2+ peripheral pulses, but now she's starting to develop a pre-tibial red-brown plaque with a waxy appearance, yellowish in color, seen on the left lower extremity. And neuro still intact and still doing fine. And there's what the shin looks like. Fasting glucose is 180. So obviously she's not well controlled on the metformin because she's eating and overriding all the metformin. Kidney function still good. Cholesterol levels are doing good. We started her on that low dose statin. So that's okay, but still that A1C is creeping up and now it's at 9%. So now that we're at 9%, 9% is that threshold. When they hit 9% and above, now you gotta start worrying about insulin. Okay, you're getting too high, the orals aren't gonna really help not do anything fast enough to get it down. When they're 9% and above, start worrying about insulin, getting that going. So how would you prescribe her insulin? So now we're gonna have to go through our calculations for insulin. So again, on the exam, you will be given the ratios. There's 2 questions that deal with calculations. The calculator is gonna be enabled on the exam. You won't need it, but just in case you're freaking out because you don't know what 5 times 3 is, for example, you want to double check, the calculator will be ready to go. So that'll be ready. So I will tell you what insulin ratio to use. She's 80 kilograms, so 0.3 times 80 gives you 24 units per day total. But remember, we give 12 units as the basal insulin, and the rest of it will be 4 units for each meal. Fast acting or rapid acting insulin. Now, I remember you guys getting confused on the insulin when it comes to the prandial dosing for the meals. The 4 units for each meal is an assumption based off of how many carbohydrates you're going to be eating. This number, this 4 units, can go up or down depending on how much you're eating. If you dose yourself for 4 units, but you don't eat enough carbs in your meal, you're going to overdose yourself with insulin, causing a hypo event. Conversely, if you dose yourself for 4 units, but you eat too much carbohydrates, then your sugars are going to go up because you don't have enough insulin to take care of it all. So that's why we also give a sliding scale. And that sliding scale is coverage for the extra insulin. So remember, the magic number for every preprandial blood sugar glucose check is 80 to 150. So if I'm a diabetic patient and I'm on insulin and I'm gonna have dinner, I'm gonna prick my finger, I'm gonna check what my glucose is before I even eat. And let's say my glucose is 200. I'm above 150. So I'm going to go to my sliding scale. It's going to tell me if I'm between 151 and 200, take an additional 2 units to cover the extra insulin in the blood, plus the 4 units to cover the carbohydrates in the meal I'm about to eat. So I take 6 units in total in that example. On any example on your exam, you will have the ranges. It'll tell you exactly. The nuance of the question comes in the calculation. Are you calculating the basal dose right? Are you calculating the prandial dose as far as like the insulin carb ratio? Are you calculating that right? And then are you calculating based off of the sliding scale that I give you to add in for anything above 150 for that glucose? So they continue taking metformin. The answer is yes. Remember, metformin decreases insulin resistance, lessening the amount of insulin required. So if you start them on insulin and they're already on metformin, continue the metformin. It's going to make the insulin work better. And bonus question, obviously, if we were alive, this one would have been a lot better. But what's the condition called? This is that necrobiosis lipoidica diabeticorum. So just one of these dermatological conditions that present due to diabetes. So case 2, okay. This is a 74-year-old male brought from the nursing home to the emergency department for evaluation of confusion and right hemiparalysis. Patient was recently transferred from the hospital to a nursing home for inpatient rehab after suffering a stroke complicated by right-sided weakness. So he's already had a stroke, and now he's confused. For the past 48 hours, the patient has grown progressively more confused and complained of thirst. Staff observed right-sided paralysis the morning of transfer. History is notable for type 2 diabetes, hypertension, and dyslipidemia. Was recently given a thiazide diuretic to help with his blood pressure on a recent hospital admission. Diabetes is managed with glyburide, but his A1C is unknown. Okay. Random blood glucose from the nursing home is reported at greater than 400. He's tachycardic, hypotensive, BP is 86/54. Disoriented to place and time, limited ability to follow commands, and does not spontaneously move his right extremities. So labs, sodium is okay, chloride's okay, bicarb's okay, BUN is high, creatinine is high, and glucose is 820. So we got acute renal failure, and we have markedly elevated glucose. Other serologies, CBC unremarkable. Urinalysis was notable for a large glucose and a small amount of ketones in the urine. But obviously we're spilling a lot of glucose in. No acute hemorrhage, ischemic changes, or masses observed in the head CT, so all the right-sided hemiparalysis is constant from the previous admission of the stroke that the patient had prior. So there's no changes in neurological status. And again, because the patient is now confused, doing that scan will help make sure that anything happened before is not getting bigger and spreading. No infiltrates or effusions visible on plain films of the chest. EKG shows sinus tach and some non-specific ST T-wave changes or ST segment changes. So what are the diagnostic criteria for hyperosmolar non-ketotic syndrome? So altered mental status with some degree of severe hyperglycemia over 800 and hyperosmolarity. Okay, so remember that's going up because they are urinating like crazy. They're losing a lot of water. That's what causing also the increased thirst they're having. Remember polyuria, polydipsia, polyphagia are the big three symptoms when it comes to diabetes. So they're going to be hyperosmolar because they're losing a lot of the water. The solvents going away, so the solutes build up. And no metabolic acidemia, no anion gap. No anion gap because they're not producing any acids. Okay, nothing's being produced. Okay, what are the key important risk factors for hyperosmolar non-ketotic syndrome? Advanced age, SNF placement, recent cardiovascular events, and also maybe undiagnosed type 2 diabetes. So how do you manage a patient with hyperosmolar non-ketotic syndrome? Fluid resuscitation is the biggest thing. Get the fluids going. It's going to help dilute out the glucose, bring the osmolarity back down. So fluid management is the biggest thing. Parenteral insulin. So give them some insulin to get that sugar levels down. And remember, watch out for potassium. Insulin drives potassium into the cells. That's why we give insulin for people with renal failure where the potassium levels are high. We give them some insulin to drop it down. However, when you give insulin to bring potassium down, you have to give glucose along with it so they don't bottom out. And this side of things, because we're giving them insulin to reduce the glucose, reduction of the potassium is going to happen as well. So remember to always check your CMP, BMP, get a potassium level, and you may have to replace some potassium as you're giving the insulin, depending on how low the potassium is before you give it. And they're not in ketoacidosis, so infusion rates are typically lowered at plasma glucose falls, and you want to get down to 250 to 300, and also reduce the risk of cerebral edema by lowering these things too fast. Next case, so that was your hyperosmolar, and this one, case 3. We have a 10-year-old female coming to the emergency department for evaluation and management of refractory nausea, vomiting, and abdominal pain. They've been going on for 1 day. They feel a little short of breath, lightheaded when standing for the past 6 hours. Examination shows resting tachycardia, mild tachypnea, dry mucous membranes, and modest diffuse pain on palpation of the abdomen. Random plasma glucose in this patient is 286. Initial BMP shows sodium 132, that's okay. Potassium 4.6, a little on the high side. Chloride's okay. Bicarb is okay. BUN is okay. Creatinine is okay. Glucose 520. And there's an anion gap of 28. So we know there's something being added into the mix that shouldn't be there. And again, they're in ketosis, ketoacidosis, so that's what's adding in to the anion gap. You can see notable ABGs. pH was 7.2, starting to creep down to that acidic side. CO2 34. PO2 is only 80. That's why they're a little tachypnic and short of breath when she stands up. Bicarb was 14. Urinalysis for large amounts of glucose and large ketones. No nitrates or leukocyte esterates were undetectable. That's ruling out a UTI. Because again, she's coming in with altered mental status. People with UTIs can present with altered mental status as well. So by making sure that leukocyte esterase was negative, we can rule out essentially a UTI. CBC showed modest leukocytosis, neutrophil count, and liver function, unremarkable. Amylase lipase, so we know pancreas is okay, EKG is okay, chest pain is okay, chest plain films are okay. So we're ruling out a lot of other things that it could be causing this patient to present this way. So how's it diagnosed? Simultaneous occurrence of hyperglycemia, ketonemia, so elevated ketones in the blood, ketonuria, elevated ketones in the urine because there's so many in the blood it's spilling over into the urine, and then anion gap acidemia. So obviously do that confirmation of the anion gap. Any secondary cause of DKA, and pneumonia and urinary tract infection are the most common precipitating causes. And your steps of treatment for DKA, hydration is always first. Prompt fluid resuscitation is blast them with fluids. You can always diurese them later and pull off if you need, but at least you can blast them with some fluids and dilute out that glucose. Insulin and obviously your potassium, so watch out for your potassium as always. Some tips: DKA and HSS are both life-threatening emergencies. Remember that DKA is due to an absolute absence of insulin. There is no insulin at all, therefore you're going to start developing ketones. With hyperosmolar non-ketotic, there's still some insulin. So because you still have some insulin floating around, it prevents ketogenesis. So that's why you don't develop the ketoacidosis with the hyperosmolar, because insulin is still there. So that's why you normally have type 2s present with hyperosmolar, because type 2s still produce some insulin. They still make it. It may be diminished and burnt out later on, but in the beginning they still have some there. Whereas type 1s is an absolute absence of insulin. Type 2 is a relative absence. And also DKA is distinguished from obviously ketonemia and that anion gap acidemia. Underlying causes, some medication noncompliance. So if they already know they're a type 1 diabetic and they stop taking their medications, they can put themselves into DKA very easily. New infection, and obviously this is the first time they know they had type 1 diabetes and they present to the hospital presenting this way. Severe hyperglycemia, hyperosmolarity, and altered mental status are defining for HSS. And other risk factors: advanced age, where are they living, underlying cardiovascular disease, and so forth. Hydration is always the biggest one. Hydrate. Insulin, and watch out for potassium, are the mainstays of treatment for both. Subcutaneous insulin is required to prevent recurrence of ketoacidosis and DKA. So obviously they have to control your glucose levels. And there's insulin infusion you can give to bring it down as well. If they're going to be in the hospital, they're going to be on an insulin infusion pump to bring their sugars back down. So that was it for that. Let me go to the Kahoot now. Okay. And you guys can join in because I'll leave it up for a little bit. Okay, while you guys are doing this, I'm gonna get some water and I'll be back in a minute. Let's see if anyone joined. Okay, give you guys another minute. We'll get started. Okay, we'll get started. Other people can join in whenever you want. Okay, first one. So type 2 diabetes accounts for approximately what percentage of all cases of diabetes in adults? How many are from type 2? Okay, very good. 90 to 95. The rest of it is type 1. Okay, so risk factors for type 2 diabetes include all the following except which one? Which one is not a risk factor for type 2 diabetes? Okay, smoking. Smoking doesn't do anything for diabetes risk. If you smoke, doesn't mean you're going to get diabetes or not. The problem is when you do smoke and you have diabetes, then you're leading yourself to what? Cardiovascular disease due to the diabetes causing damages to the epithelial lining. Smoking also causes damaging to the epithelial lining, so that's where that one comes in. Untreated diabetes may result in all the following except which one? Untreated diabetes. Very good. Tinnitus. Prediabetes is associated with all the following except what? So prediabetes. Increased risk of developing type 2, yes, because you're pre-diabetic. Either you become type 2 or you go back to normal glucose. Increased risk of CVD and stroke, yes. Pre-diabetes increases your risk. Impaired glucose tolerance is what pre-diabetes is. Essentially, you do have an impaired glucose tolerance, but you do not have an increased risk of developing type 1 diabetes because that is all due to an autoimmune problem. Diabetics are at an increased risk of heart disease if they also do what? So I kind of mentioned this one before. So if you take aspirin, it's to reduce your risk. If you have high HDL, that reduces your risk because HDL is the good cholesterol. You want that as high as possible. High fiber diet, very good. And obviously smoking is the one that you don't want. For a type 2 diabetes, which of the following is considered controlled? So for a type 1 diabetic, A1C below 7% is controlled. A1C between 12 and 15, preprandial glucose over 200, or a fasting glucose over 150. Which one is considered controlled for a type 2 diabetic? Yeah, A1C below 7%. That's your goal. That's what you want it to be for type 2 diabetics. How do you treat the proliferative retinopathy? So tonometry is looking at pressure in the eye. Fluorescein angiogram is looking for things on the lens. Antibiotics, do we have an infection with this? Nope. This is laser surgery, that photocoagulation, to take care of that. So remember, also work backwards. So which of the following diabetes drugs acts by decreasing hepatic gluconeogenesis? So make sure you know how the drugs, the mechanism of action for the drugs and the classes of the drugs and which drugs are in each category. That's the biggest thing that you guys really need to know because we've gone through diabetes many times together. Just 126, 6.5, 200 for the 2 hour. Those are your criteria for diabetes. Everything else you got to know is all about the treatment and the prevention of other problems when it comes to diabetes. That's a lot of the stuff you guys got to study. Not so much, yes, you know how diabetes, the pathophysiology, you know how that works. It's all the treatment stuff you got to know. So which of the following is a way to decrease your blood sugar? Will increasing my carbohydrate intake reduce my blood sugar? Decreasing peripheral glucose uptake, is that going to decrease my blood sugar or increase it? Increased hepatic glucose production, that's going to be dumping more and more sugar into the bloodstream. So raising your sugar. So the way to decrease it, increase insulin secretion. And that will take care of your sugars. Which drug is an insulin secretagogue? And you'll have both brand and generics for all the questions. Okay, micronate's very good, so make sure you guys study the classes. What's the mechanism of action of Januvia, sitagliptin? What's the mechanism of action? So this is another good question to work backwards with. Figure out what class of drugs does this, what class of drugs does that, what class of this, what class is this. So Januvia inhibits the enzyme that breaks down GLP-1 and GIP. What's the formula to calculate insulin to carbohydrate ratio? So the red one, that is going to tell us our total daily dose. Okay, 0.3 units per kilogram times your kilogram body weight, and that will tell us our total daily dose that we need for insulin for the day. The yellow one, total daily dose divided by 2. That's going to give us our basal dose. How much long-acting do they need per day? The green one, total daily dose divided by 2, and then that number divided by 3 tells us the prandial dosing on average of what you should be having for every meal. The insulin carb ratio is 500 divided by your total daily dose, and that number is the amount of grams of carbohydrates for every 1 unit of insulin. And that is what you would use instead of the 4 or the 5 units for every meal. That's the more specific one if you know how much carbs are in your food. If you don't know, don't use it. So 500 divided by total daily dose is your insulin to carbohydrate ratio. Undiagnosed type 1 diabetics will usually present with what? So hyperosmolar non-ketotic state, nope, because in order to be in that, you need to have insulin. Stroke, they don't present with a stroke. They don't present with extreme weight gain. If anything, type 1s are very slim, cachectic almost, not putting on a lot of weight. And then obviously they're going to present with DKA. Okay, in which scenario is self-monitoring of blood glucose required? When should you be checking glucose 4 times a day? Do you need it with metformin? No, because metformin doesn't cause hypoglycemia. Therefore, it's not required. It's just recommended. Diet and exercise therapy. You're not on any type of glucose lowering drug, so you don't need it for that. Prediabetes, you don't need to monitor. Not required, but if you're on an insulin pump, then yes, you have to be monitoring your glucose so you know how much to be giving yourself. When should a prandial dose of insulin be decreased? So which of these scenarios would you want to decrease the amount of insulin that you give yourself with a meal? If you're eating more, you want to increase the amount of insulin because you're eating more carbohydrates. You need to cover for all those insulin, so you take more. Higher preprandial blood sugar, you have to cover for those higher blood sugars. Remember, 80 to 150, so anything over than that, you have to cover. If you plan on exercising, lower your prandial dose. Remember, right after exercise, your muscle will take in sugar by itself without the use of insulin. So if they take their normal dose of insulin and they're exercising, you've put them at a risk for a hypoglycemic event because they can bottom out. What is the Somogyi phenomena? So make sure you know the difference between the Somogyi and the dawn phenomenon. What's the underlying pathophysiology for both? And what happens? Okay. Somogyi is an AM hyperglycemia due to nocturnal hypoglycemia. So we're bottoming out overnight, and what's happening is we're getting a reactive hyperglycemia. So when we wake up in the morning, our sugar is high. The dawn phenomenon is the red one, AM hyperglycemia due to growth hormone. Remember that growth hormone comes out at night when we're in deep sleep. Growth hormone causes blood sugar levels to go up. So that is the reason for the dawn phenomenon, with growth hormone spiking at night causes our blood sugar to go up. You wake up in the morning and you test a fasting one and you're high. That's due to the dawn phenomenon. And can we reduce by removing intermediate insulin at bedtime? No, that's actually how you help correct the Somogyi phenomenon, is by making that long-acting basal insulin, switching it to an intermediate insulin, which won't have the spike of insulin. It'll have a more gradual profile. Take it twice a day, and that will help with the Somogyi phenomenon. Okay, 2 more. Which of the following is a proper treatment of DKA? Getting glucose of 150 milligrams per deciliter per hour. Rapid early correction of acidosis with sodium bicarb. Correction of severe hypokalemia with insulin. Or empiric antibiotics if you suspect underlying infection. So which one is the correct one? Okay, this one's the green one. So, correction of glucose at 150, you don't want to drop them that low, keep them a little higher. Correction of severe hypokalemia with insulin. What are you going to do to that patient now when they already have low potassium and now you're giving them more insulin? It's going to make the potassium drop even more. So the blue one is not correct. And we don't correct acidosis with sodium bicarb. Sodium bicarb is used as more like a last resort. You don't want to correct the acidosis with bicarb. The acidosis is due to the ketosis that's going on, so you don't need to worry about that. But yes, if they have an underlying infection, you give them antibiotics. That's going to help them with the DKA. Yes, the number one treatment is hydration. Fluids, and then you worry about the insulin after that. But remember, what are the other underlying causes for a patient presenting with DKA? And one of them can be infection. So when you're reading this question, this is a question that kind of makes you think, because their first line therapy that you want, we don't know what it is. It's not listed. So you have to kind of, what's the next step? And kind of go from there. For hypokalemia, you'll have your reference ranges on your exam. You can hit the link. So make sure you guys do that. Just know if it's like 3.4, 3.5, replace potassium when you give the insulin. 3.5 and below, you want to replace. Anything higher than that, you should be okay. Just watch it. Okay. This is the last one, and after this, if you want to ask any questions, throw it in chat. If not, I'll see you tomorrow morning. So which of the following lab results is indicative of hyperosmolar non-ketotic state? So when you're looking at this one, remember the differences between DKA and hyperosmolar. Hyperosmolar is going to have a lot higher glucoses. So we know right there it's going to have high glucose, so we know we're looking at the 1,000 ranges. The next thing we look at is the pH. Hyperosmolar non-ketotic state does not have any acid production. So therefore, the pH is going to remain normal, and therefore this is the green one. pH 7.4 and glucose of 1,000. Now, which one would be indicative of type 1 diabetes, DKA? Which color would be DKA? I don't know the delay here, but I'll just give you the answer. So the answer is going to be the red one. In DKA, they don't have very high glucoses. It doesn't need to be that high, and they're going to be acidotic. So that's 7.18, the acidosis due to the ketosis that's being generated. Okay. So that's the review. Oh, DKA1. So that's all I got for this. I'll leave it here. So if anyone has any questions, feel free to type them in chat. Otherwise, I'll see you all tomorrow morning, but I'll stick around for any questions. So I will let you know in the question what conversion to use. So that 0.3, 0.4 has to do with insulin sensitivity, if they're never taken insulin before, and then also their weight, if they're obese or not. I will give you the conversion, and I'll tell you 0.3 or 0.4 their body weight, and then you just figure the rest of it out. So the next one you add is usually like a glyburide. You add on to metformin. Let me open this up. Hang on a second here. It should also be in your endo section as well. Okay. Okay. So now you guys can see this. So this is like a little flow chart that kind of walks you through. Okay. So this first thing kind of talks about people, not this one. Here's one. Lifestyle therapy. This should be in your PowerPoint as well. So here's the thing. Here it is. Okay. So monotherapy, entry less than 7.5. Metformin is the gold standard. You start that. If metformin doesn't really control it, you could add a second therapy with a GLP-1 or SGL2 or DTP4 inhibitors. You can have those. Then if you need triple therapy, you go from here. This over here, entry A1C at 9%, that's what I was saying before, that if you're over 9, you have to start insulin. You can't keep them on anything else. It's not strong enough. Once you're over 9%, you kind of need the insulin. This stuff is not going to be strong enough to get them back down in a timely manner. So this is where your next one is. But metformin is always the first one. Then you move on to the next one and the next one. Obviously, TZDs avoid because of the heart problems and the heart complications. Here's another thing too when we talk about insulin dosing and changing of the dose. So again, how you start them off. If their A1C is over 8%, obviously you need more insulin to cover for that extra stuff. So it's going to be higher, less than 8. But again, I will give you these ratios. Don't worry about memorizing these things. Make sure you understand how to change a dose. If you had to make changes or either up or down on the insulin. This chart talks about the different hyperglycemic medications. Do they cause any hypo events? You know, obviously sulfonylureas do insulin. Obviously, yes, will cause hypo events if you use too much of it. Any weight gain, weight loss, what happens with the weight? Metformin may have a loss. You gain a little bit of weight with TZDs, gain weight with insulin. Any renal issues, so don't give insulin if they have any, metformin if they have any renal problems. Any GI symptoms, yes, you do get some GI discomfort with metformin. Some people do have like a little nausea with it. Any heart profile, things to worry about, bone issues, ketoacidosis, can they occur or not? So this is a good summary slide. So this is what tells you about intensifying therapy. To go from there. And then this again talks about your risk factor modifications for dyslipidemia as far as your statin therapies, high, very high, or extreme. You know, obviously most of the people are going to be desirable for these in the high areas. You want them less than 100 for your LDLs is the big one. ApoB starting to measure a lot more now. ApoB is tied to your LDL, so that's why they go together. Lowering LDL, it's statin, always a statin first, so remember your statin therapies. For blood pressure management, goal is 130 less than 80. ACEs or ARBs are your great first line. They're the renal protective. And then if you need to intensify therapy, you can add a calcium channel blocker, a beta blocker, or a thiazide diuretic as well. And obviously the goal is to get to your target blood pressure and your target LDLs. And this talks about lifestyle therapies and everything, so that's it. They're not there? Okay, let me pull them up. Let me get them on there for you. Okay, they are there. Okay, I thought they were. Let me make sure the Kahoot's there as well. Yeah, the diabetes algorithm. And diabetic cases there, and the Kahoot's there too. So you guys are good. You got it all. I hope everyone had a good spring break. Rested up for the second half of your semester. I'm trying to do anything else to review. I don't think so. Like I said, the biggest things are the treatments. And Classes of the drugs, that's the biggest thing. Especially in the type 2 lecture with all the orals. Make sure you also understand on the types of insulin, know the short acting, the long acting, the main ones. For the orals, know the classes, mechanism of action. Know your lab values. Know screening. When do you start screening for diabetes? What types of tests do you have to do? Every time you see a diabetic patient, how often should they get their ophthalmologic testing done? So the screening stuff, make sure you know all that stuff as well. So, any other questions? I don't know if you guys hear my dog barking or not. I don't know how sensitive the mic is. Well, if no one has any more questions, we'll end it now. So I will see you all tomorrow morning. No more questions. So I'll see you guys tomorrow morning. You guys will be fine. You guys know this stuff. I'll see you guys after the exam. And it's our second unit of endo tomorrow as well. All the fun stuff rest of the semester. So, okay, guys, have a great rest of your spring break. See you all tomorrow morning.